Good afternoon, everyone, and welcome in today's nursing webinar session. And today we are going to discuss about the very deadly, silent, and the serious condition on VTE, which is nothing but venous thromboembolism. Its risk assessment and the role of thrombolytic therapy. So, myself, Shanti Bhattacharya, the moderator for your session today, and our expert panelist, Dr. Bhavin L, who is our endovascular and vascular surgeon, senior consultant, and vascular surgeon specialist. I think sir is busy inserting ECMO for one of his critical patient in ICU. And once sir is finished, he will join us shortly. By then, let me also welcome our very efficient and passionate mentor, who is none other Grace, who is a clinical instructor from Yashoda Hospital, Secunderabad. I welcome you, Grace, and let us start this session. Sir may join any time in between. You can start with the first slide.
Thank you, ma'am. Good afternoon, one and all. My name is Grace. I'm a clinical instructor in Yashoda Hospitals, Secunderabad. So here we go. We can read about what is venous thromboembolism and also the risk assessment and role of thrombolytic therapies. What is VTE? We have a question in our mind. What is VTE? VTE is nothing but it's a thrombosis condition where the blood clots in the veins and pulmonary artery. It's a preventable medical condition, can cause disability and death if not treated properly. So here we have a picture about the thrombus where we can see easily over there. And next, coming to the prevalence about the pulmonary embolism. Annually, we have 1 to 2 events for the 1,000 population, and the DVT is for lower limbs, and also pulmonary embolism effects on the pulmonary artery, which we have shared about the DVT as well as the lungs, where the embolism was there, and the damage also we can see in the slide over there. And next, here we have some incidences of VTE. Hospitalized patients for 1 lakh, there were 330, and for the general community, 8 per 1 lakh. And also 90% of the DVT occurs in the lower extremities, as well as for 6 lakhs yearly for pulmonary embolism cases. And the instances of DVT in different surgeries, here we go with hip and knee arthroplasty, and the major trauma and the spinal cord injuries too. And the minimum to maximum was like 40 to 60% of VTE prevalences. And for major trauma, it was like 40 to 50%. And for the spinal cord, it was like 60 to 80%. And overall, 70 to 80% of sources of PE is only the DVT.
So here, Grace, 1 minute. So yes, here, as per the studies and data, we always get to see that more than rampant of 260,000 patients, hospitalized patient contracts P or DVT per year. So one must be very careful in assessing the DVT patients. Next slide.
Yes, we have some causes. The prolonged sitting, standing and long traveling, and people who do not seek medical conditions, attentions, and obesity, high sedentary lifestyles, and family history of stroke and other risk factors. These are the contributing factors and the causes for the VTEs. Next, coming to the virtuous triad, there are 3 broad factors which is contributed to the thrombus. Here it is called as a virtuous triad. From the venous stasis, second is venous damage, and third is increase in blood coagulation. Where it starts with venous stasis, then it comes to the damage. Then finally, it leads to the increase in blood coagulation.
So this is one of the very, very vital parameter and golden rule of assessment for the clinical vascular surgeon. Upon admission or any ICU patients, they will always like to see the virtuous triad, whether how far the venous stasis or the venous endothelial injury is taken place, or are there blood coagulity high parameters are seen in the patient's body. So this is how the doctors will assess this triad upon the admission and reassessment for the ICU patients. Next slide.
Yes. Next, we have some contributing risk factors too. And from major general and orthopedic surgeries and lower extremity paralysis due to spinal cord injuries and any fractures to the pelvis and hip or long bones. These all are major fractures, and cancer of the lungs, brain, and also gastrointestinal tract. And the varicose veins, if they are untreated, it may also lead. And women on hormonal replacement therapies too.
So that is the reason we tell the nurses after they receive the patients, especially the orthopedic polytrauma, multiple trauma patients, and women who are already receiving hormonal replacement therapy and reaching to the menopausal age, we always tell them to go for the preliminary health checkup. And in the hospitalized scenario, we must assess the patient for DVT, any guarding pain, any leg swelling, any kind of shortness of breath should be always escalated to the doctor. Next slide.
And the assessment done by the doctor for knowing this VTE, there are some clinical examinations and also the history. Here the history plays a major role, like past history or current history, and the diagnostic test to evaluate this VTE, and also the patients on oral anticoagulants. This is a very important thing which the doctors will be assessed, and also they ask the question about this past and present, whether they are on anticoagulants or not. And next, we have some.
Here I would like to I think Dr. Bhavin has joined us. Hi, sir. And sorry, I heard that you are busy in doing ECMO. So are we okay now? Well enough to go for the session, sir? Unmute yourself, sir.
Hi, Shanti. Sorry, I was stuck in
It's okay, sir. Let me just again retake on the few statement that to all the viewers here, we have Dr. Bhavin Ram, who has joined right now. He's skilled, very competent in the vast vascularity of vascular surgeries. He's none other our Dr. Bhavin from from Secunderabad, Yashoda Hospital, who is our endovascular and vascular senior consultant surgeon and very passionate mentor. So, Grace, would you like to go to the previous slide on the virtuous triad? Virtuous triad, yes. Yeah, sir, we would like to, though we have only done with 2 or 3 slides, I think this is one of the golden rule of assessing the patient when you all see the patient. So what are the components and which component is very more prominent and which has to be done as per the age wise or for the maternal mothers? What is the concept about? We would like to know as a nursing.
So apparently, Shanti, here, if you see, there are 3 main aspects.
Yes,
One
sir.
is venous stasis. Stasis is nothing. When you are immobile, your blood is accumulated in the calf and leg veins, right?
Yes, sir.
That is working as a stasis. When stasis happens, there are multiple coagulant factors which will get activated. And that's why your venous channel will become more prothrombotic. Prothrombotic means they are prone for thrombosis more than the normal. So that is a venous stasis. Second is, so venous stasis you will see more in ICU patients or ortho patients where they are not mobile, they are not moving, spinal cord injury patients, trauma patients, and after major surgery. Then comes the venous damage. Venous damage means when your artery or vein, anything gets injured, your intima gets injured, then body's normal response is to make everything procoagulants, or you can say thrombosis. Why? Ek bar injury hoti hai. It means body thinks that vessel is open and now blood is coming out. That's why they will try to form a clot over there to stop the bleeding. And because of that, that part will become prothrombotic or thrombus formation becomes more common. So venous damage you can see in surgery or trauma patients. And then comes third part, increase in blood coagulation. So increase in blood coagulation, that thing can happen in cancer patients also. Why? Because in cancer patients, because of that thing only, blood becomes extra thick. So all 3 parts comes together. It is called virtuous triad, and all 3 contribute towards forming a clot and DVT. And that's why if you see, all 3 factors will be seen in any major surgery patient who is not mobile, or any ICU patient, or on patient which who are on ventilators.
Yes.
So that's why they are more prone for developing DVT. And that's why this is important to remember.
Yes. Next slide, Grace.
Yeah, we have discussed about the risk factors also, sir.
So, sir, here we would also like to know that why women who are reaching to the menopausal or on the hormone replacement therapy, are they also very much prone to have this thrombotic condition or DVT?
Right.
Yeah.
So it's not about just women who are on a hormone replacement therapy, but young female who are taking oral contraceptive pills or
Okay.
other hormonal tablets. Right. Sometimes if you see people, few female patients who are having polycystic ovarian disease, PCOD, they will be on hormonal treatment. All this estrogen and progesterone, particularly, they will cause procoagulant state. As we saw there over there in virtuous triad, that third part is extra thickness in the blood, which will be done by either hormone replacement therapy or this OC pills and pregnancy. And because of that, women who are taking hormone replacement therapy, OC pills, or during and after pregnancy, their blood is extra thick and they are more prone for developing DVT. So that's why we have to be careful.
Yes. Go to the next slide. You can skip the virtuous trade. Yeah. So here yeah, you can read this slide, please.
We have some risk assessments done by the doctors. Here we have some clinical examinations and the history, past history or the present history, and the diagnostic test, and patients who all are on oral anticoagulants. Next, we have some diagnostic tests. They are Doppler ultrasound of the legs, color venous Doppler, and the CT pulmonary angiography and nuclear studies in the detection of pulmonary embolism. And the blood test, it's called D-dimer. If it is less than 500, it shows negative. If it is more than 500, it shows positive, and it's an alarming sign for this DVT.
So here we see here the DVT risk assessment. We have developed this checklist of taking from the Wells score criteria, and it has to be done by, we have privileged and empowered all our nurses upon admission and reassessment of your patient, especially in the ICU scenario. We have got this 1 to 10 parameters, which always says about right from the length of stay and the bedridden state of the patient, leg swelling, calf swelling, tenderness, etc. So 1 to 2 is always the moderate score being remain, and above 3 is the highest score. And I think during the moderate score itself, the nurses or senior nurses should escalate to the doctor or to the intensivist whether the DVT prophylaxis or any thromboprophylaxis regimen has to be started or not. So I urge all the nurses, so please look onto this checklist and just adhere to the regimen. Next slide, please.
Next, we have some higher drugs, which are the one of the very high alert medication. This is the, and more of sound alike, and must be administered after cross-check policy with the intensivist or with the senior nurses. And the more important thing is not to be handled by fresher nurses. And the drugs which we are using here are elaxin, altiplase, tenecteplase, clexin, heparin, which we can have the pictures of this in medicines also. And next, coming to the thrombolytic injection altiplase, we have two different doses. One is in 50 mg and one is in 20 mg. Then altiplase, where we have to use this dissolves, it should be used, and it will be used for dissolving fresh clots quickly and prevents damage to the heart muscles, and administered drugs as per surgeon's prescribed order only.
Sir, here, apart from this indications, I'm sure there are many indications as well. There are any more indications which we all should know?
So, Shanti, basically, altiplase, it's a thrombolytic agent. I think we had discussed this, you and me. Now, I would like to emphasize here again. See, you people should be having knowledge of this drug. But again, you people are not authorized to use this drug, frankly speaking. Right. Whenever you come across this drug, if you want to change the dose or you want to change the ampule or one injection is over, you want to start other, always ask the intensivist or the person on call over there, whichever doctor is there, because this is a very, you can say, high risk drug. Yes, a little bit dose here and there, and it can kill a person or it can totally change the result of the thing. So in DVT, generally DVT and pulmonary embolism, we use it to break the thrombus. And the second line, I would just like to say that it doesn't prevent the damage to the heart muscle. It doesn't do anything to heart muscle. What we are trying to say here is in heart attack, there is a clot formation which is not allowing blood to reach to the heart muscle. Now you give the drug, that pipeline will be open, blood will reach to heart muscle, and then it will stop the further damage to the muscle. So it is not this drug which is causing the thing. It is the effect of this drug which is opening the vessel, and that's why muscles are getting the more blood circulation, and that's why damage is stopped. So only effect of this drug is to dissolve the fresh clot, right? And definitely, whenever you come across, you are having any doubts, call the intensivist or the person on call.
Yeah, thank you, sir, for your corrective points here. Next slide, Grace.
And here we have some pictures of the medications. That is tenecteplase, it's in 20 mg, and we have Elaxim for 40 mg. And next we have some low molecular weight heparin, and that is Clexin 40 mg and the Clexin 60 mg, which we can see the pictures over there.
So regarding this LMWH protocol, the question is to you is, sir, like as we see a person with the clinical features of DVT or any thrombotic condition, so do you advise them as in terms of prophylaxis and how long and how they should be taking these medications, even if they are at home?
Yes, Shanti, now I'll take 2 more minutes here. First thing, as Grace had shown us the slide and that Wells score part, that how to think about DVT. So now I'll start from that assessment part only. Whenever in a ICU or in a ward where patient is high risk, you come across few things like patient is having leg swelling,
Yes.
persistent fever, leg temperature is increased, then first suspicion of DVT should come. Okay. With that, if tachycardia and little bit breathlessness, then you can say that it can be associated with pulmonary embolism also, DVT plus P. So whenever you come across this in high risk patients, always think about DVT. If you think about that, then second part is you inform the people. What generally is done is we do the Doppler with simultaneously D-dimer. D-dimer is having negative predictive value. Negative predictive value means if D-dimer is high, there is a high chance patient is having DVT. And if D-dimer is low, then you do not have to worry about DVT, right? And venous Doppler, do it. Now, coming to this enoxaparin, or you can say low molecular weight heparin. Either it is enoxaparin, dalteparin, or unfractioned heparin, whichever we are using, right? That either prophylactic dose or therapeutic dose. Prophylactic means DVT is not there, but you are trying to prevent. Why? Patient is immobile, there is a high risk, they may develop DVT. At that time, what dose we give is 40 milligram enoxaparin subcutaneous daily. And if you are using dalteparin, then it is 2,500 or 5,000 international units subcutaneous daily for the prophylaxis.
So here we always tell the nurses also, like how you inject your insulin to your patients, always rotate these sites. I think, yes, you will also agree with me, sir.
Yes. So just a small difference here. This is subcutaneous, not subdermal. So enter into subcutaneous space. That's it. And this pre-filled syringes, if you try to inject hard, then also you will not reach to the muscle. Why? Because they will give you a short needle only. Right? So that's the advantage here. Pre-filled syringes.
Thank you. Grace, next slide.
And next, the cross-checking and prepare the dose under supervision. Here we can have the picture where the doctor is there and also the sister is loading the medications. And which is the foremost important thing is label the syringe and for the infusion pump too. This practice prevents medication errors and zero medication errors we can do. This is a picture we can see. And next, coming to the while patient, and the nurses must monitor what are our key things, and we have to be very much careful about during giving these medications are vital signs, which plays major role, and also the bleeding. And do not mobilize the patient for 24 hours, and strictly avoid pricking to the thrombolytic site or to the limbs, and cuff, PP cuff also, the tying, and this all should be strictly avoided, and avoid any kind of invasive procedures like Foley's catheterization to avoid further bleeding. And
so here, just a minute. So, sir, apart from this, we nurses, they should be always 24 hours. They should monitor the patients, whether the patient is receiving intra-infusion of thrombolytic agents. Any other points or any other early warning signs they should escalate to you, or should you tell to the nurses?
Sorry. So just two things we should keep checking here. One is wherever you have done the puncture, like sometimes we are giving it through the groin femoral artery or radial artery, right? Or it is a intravenous, then those puncture sites you have to observe for any swelling, hematoma or anything, because that is the most common thing. And particularly in the groin, sometimes we will miss it.
Yes.
Why? Because groin is not exposed. Hand, yes, it is exposed. So that is one thing. Second thing, all these patients, if you are seeing gradual increase in the heart rate, tachycardia, with little bit hypotension, it means he is or she is bleeding somewhere inside or outside. Whenever you see this increase in heart rate and decrease in blood pressure, that you should alert the intensivist or whoever is on call at that time. Don't ignore that sign.
Yeah, next please.
So we have some endovascular newer treatment modalities. This first one is catheter-directed thrombolysis. Second, mechanical thrombectomy or the aspiration, and the IVC inferior vena cava filters too.
So when we talk about these very fine-tuned, minimally invasive procedures done by, sir, please unmute your, yeah. When we are talking about this newer treatment modalities done by you as an expert, and maybe these are only few, and I'm sure you may be doing many more interventions. And also, do you predict the outcome to the patients? I think it is very superb in giving the decision-making process. What are the benefits than, apart from this, than the conventional surgeries?
So apparently now you can say in DVT, conventional surgeries are very rare because of all this advancement. Whenever young patient means up to age of 55 to 60, before that, we like to do the catheter-directed thrombolysis or mechanical aspiration. In this, what we do is percutaneously, we either puncture popliteal vein or in the groin femoral vein. Through the puncture only, we give the thrombolytic agents, and with the large bore aspiration catheters, we remove the clots. So it's a simple procedure. Under local anesthesia, it is done 2 to 4 hours, and you remove the clots. So now conventional DVT treatment is just give anticoagulation. That has been changed. Whenever we feel suitable patient, young patients, we try to explain them that these are the better procedures and that will remove clot immediately. On other hand, when you give heparin and other oral anticoagulations, body takes 3 to 6 months time to clear that clot. Here we remove it within 2 to 4 hours. So you can understand that now 3 or 4 hours your vein is open, which is better after 3 months or immediately for 4 hours. So that's why these are important.
Yeah. Next slide, please.
Next, we can see this thrombus aspiration with the evacuation of thrombus used by syringe, and we can see the clots over there. And next, popliteal vein access, which the newer technique, which we have already told by the Dr. Bhavin. This is ultrasound guided popliteal vein puncturate popliteal fossa in the prone position. And this is a post-thrombolytic syndrome. We can differentiate the limbs over there.
So here, sir, just we would like to know about this image.
Yes,
so, yes.
So apparently, if you show these images, people will not understand what we are trying to tell here. Here, why these pictures are there? Because we are trying to show you that what complication can happen after DVT. So first, that black leg you are seeing, that is not a gangrene. That is a normal leg. This patient had DVT 7 years back. Later on, gradually, because of that DVT, she developed venous hypertension, gradually skin eczema, black discoloration. And if you see on the dorsum of the foot, small ulcer, right? That is a thing. And the other gentleman is also having one big venous ulcer. He had also DVT almost 8 years back. So this is called chronic venous insufficiency related venous ulcers, which are due to the DVT which had happened in the past. And looking at this, we should not ignore the DVT because it will have very bad consequences in the future. And that's why previously I emphasized that young patients, we should try to open up those block channel. Why? Because they will live longer. And after 8 or 10 years, they can have such kind of problems. To prevent this, DVT should be treated by thrombolysis or thrombus aspiration. So this is a picture for that purpose.
So I'm sure, I think they are doing very good and able to do their ADL after your superb interventions. So yeah, next slide.
Yes. And the ICU nurses must, adequate hydration is needed and elevate the affected extremity and advise compression stocking or TED stockings only in absence of shortness of breath, leg swelling, or if you find any risk for DVT. And administering analgesics is very most important, and encourage the patient to walk post-treatment and resume all activities of daily living.
I think we have already spoken about the early warning signs by you, very well explained by you. Yes, next slide.
Next, we have some mechanical things like prophylaxis, like mechanical devices, graduated compression stockings that are GCS, and intermittent pneumatic compressions, and some pharmacological agents such as unfractionated heparin and low molecular weight heparin and fondamponics, as we have recently looked over the pictures. And here we can see that some GCS and the Flotron pumps, which we are using in our hospital.
So whenever the patients are on this lower extremity Flotron or SCD pumps, we nurses, we must always make sure that the garments are not worn too tight and too loose. One finger pass should be there, and motor pump, the reading should be adjusted properly. There should not be any air leak present. I think, yes, sir. Yeah, next slide.
Next,
sir, this is again, we need your, last preventive measures for the general population, or you can say the nurses, because they are the ones, and you are the ones who always stand for a long time doing the surgeries and all. So patient undergoing major surgery are contracting the DVT and it increases by 30%, though the absence of optimal prophylaxis are being seen. So what is your preventive tips if you wish to like to give to the general population or to the healthcare professionals?
So again, Shanti, as we had discussed the virtuous triad,
Yes.
right? All those things will come back here in the last slide. How you avoid venous stasis. When you are putting a calf pump, what it does, it activates the calf, right? And the blood accumulator over there, it is pushed upwards. So stasis is prevented. What is dehydration? Dehydration, it means your blood will become extra thick. So generally after major surgery, patient will be NBM and they will become dehydrated. So again, you treat the dehydration, you are treating the stasis part, right? And you are preventing happening the damage to the venous wall. So all these things, if you say it is related to the virtuous triad, so a common advice would be keep hydration proper, mobilize the patient as soon as possible. If you are not having calf DVT pump, passive calf flexion, extension, and compression will be helping, right? Every 2 hours or 3 hours, 5 minutes by nurses or teaching it to the relatives.
Yes.
Right. Every time you do not require the calf pump because we can't have that many calf pumps.
Yes.
Right. And on top of that, if we should ask the surgeons that if risk is not that high, we should start them on prophylactic heparin or low molecular weight heparin. Right. Those are the few things. Second thing, as a nursing staff, we are also medical or paramedical staff. We are also prone for developing DVT because we will have more standing job without moving around. So at that time, again, like patients, we should also be keeping ourselves well hydrated. Try to use either TED stockings or class 2 compression stockings. And when you are working at a one station, take time and have a small walk, 5 or 7 minutes every 1 or 1.5 hours. That will activate your calf pump. So I think this will help us in preventing ourselves also from getting the DVT.
Yet very simple session, and I thank you, though you are very busy, but you have really contributed very well towards the nursing webinar, and thank you so much, Grace. And as we all know, VT is such a very vast ocean where we have to speak about other thrombotic conditions called the DVT and P. I think all nurses and anybody who is watching this live webinar, you can just log in into www.yashodahospitals.com and you can see Dr. Bhavin's health talk, a lot of other interventional procedures, and do watch nursing webinar Thursday at 3 p.m. Thank you so much. Thank you, sir, and thank you, Grace.
Thank you, Shanti. Thank you, Grace.
Thanks.
See you.
Thank
Bye.
you.